showed you really in a wonderful way what chronic sleep deprivation means. And I would like to show you how currently we deal with this. This is a child whom I had the privilege to saw at the age of 4 years. She has a neurodevelopmental disability. She has falling asleep and sleep maintenance problems. She has the comorbidities ADHD, global developmental delay, sensory processing abnormalities, and due to her falling asleep situation, the problems, or the challenges, she received at the age of 2 years and 7 months melatonin. She received, it didn't help a lot, after an observation of 2 months clonidine, and then after 4 months trazodone, which is a second generation antipsychotic. Obviously her restlessness increased over the day, so she received a stimulants in order, psychostimulants in order to treat her ADHD behaviors, and obviously something went wrong here because it was immediately changed. I know the story. She developed a motor-driven restlessness, which we would retrospectively interpret as akathisia-like syndrome, which means a motor-driven restlessness. And then finally they agreed to put her on stimulants and clonidine in order to manage her sleep challenges. It is a complex story, and how to start? So the entire discussion, Children's Sleep Network, started for us here last year with the Peter Wall Exploratory Workshop. Dr. Carleton and I hosted, and we agreed to collect in a different way information. But before we go further with it, I would like to give Dr. Carleton, who is unfortunately not here today. He had to leave town for an international conference, but last week we made a mini recording, and he's explaining his view.
I want to give a short video introduction to this Sleep2Treat conference that's going on, and I apologize that I'm not able to join you. One of the key elements of clinical pharmacology is to establish therapeutic targets before you begin drug therapy. So for those of you that have children that are on medication, or for clinicians who are thinking about prescribing medication, one of the things I want to talk about is this principle. So we often talk about drugs achieving goals, right? So for example, I often say to my students that there are only 2 reasons to use drugs in the universe. One is to prolong life, the other is to improve quality of life. That really is the only 2 reasons to use drugs. But when you're prescribing, or if your child has medication, what's more important is monitoring therapeutic objectives. What is the specific symptomatology that we're using to judge whether there's success with this particular agent? The second issue that's often missed in this setting of therapeutic objectives is what are the potential adverse effects that can occur, when might they occur in relation to drug use, so early, after a week or so, or later on, and how do we monitor for these events in order to prevent drug-induced harm. So the principle of setting therapeutic objectives for both drug effectiveness and drug harm is what I'm speaking of. And once you set those targets, those objectives, you then need to decide, what do I monitor for, when do I monitor, how often do I monitor, and most importantly, what do we do if one of these objectives occurs. So if, for example, we reach a therapeutic objective and the drug is effective, then we would very likely continue to use the medication. In the case of antibiotics, there's a defined course. You complete the course of 10 or 14 days, and then you stop therapy. Sometimes the courses are shorter. But for other medication, let's say for sleep medications or for any kind of mental health medication, often these are used long term. So we have to continue to reevaluate effective outcomes. We also need to ensure that any adverse effects that occur are continued to be examined over time. One of the key outcomes when you use mental health medication or medication for sleep is to continue to look at issues relating to harm. And it's not so obvious. Sometimes drugs cause behavioral adverse drug reactions, things that change a child's behavior for the worse. So we might see aggression, we might see sleeplessness, we might see irritability, frustration, confusion. Those are the kinds of things that you need to watch for as a parent to ensure that a health professional that's the prescriber is notified of these as soon as possible to make an adjustment. Usually these kinds of adverse drug reactions are dose related, meaning that a lower dose can help to eliminate them. Unfortunately, effectiveness is often dose related. So if you lower the dose too much, you can't get an effective response either. So it's important to discuss those issues and recognize that drugs can cause both benefits and harm in patients, and they can continue to monitor appropriately.
So what you speaks about is, besides the big picture, the targets, and the question is, who is monitoring and how are we monitoring? One more patient, a 12-year-old girl with a neurodevelopmental disability. On the left you see the medications which have been given for treating her daytime behaviors. On the right side, her sleep and daytime behaviors. And you will see on the next slide the life trajectory of this patient, and so the entire cerebral charts plot on one graph. We are, by the way, very proud of this presentation mode. And you see that the medications started, the sleep problems have been mentioned actually in the chart for the first time when she was 7 years old. Here on the x-axis you see her age, and you see also that in the narrative of the parents, sleep problems were mentioned already at 19 months. Now here you see the medications, and with the medications, there are 3 emergency admissions at the intensive care unit of mental health, and parallel you see that there is a breakdown in the home situation and she begins to live in foster care. This is when we discuss patient trajectories, everybody focuses on something from his own viewpoint. When you get this overview, you realize that the main problems started obviously with somehow sleep, and what happened here is that with the medications, a certain situation was initiated. She received antipsychotics, she reacted to behavioral adverse drug reactions, she received in addition stimulants, and the entire cycle repeats a second time till we could diagnose her and treat her. This is a crisis situation. And now from a healthcare administration perspective, the question is always, our system costs lots of money, where can we save money? We believe it will not be, where is the cursor? We believe it will not be saving here 1 or 2 services that will not bring any major differences, but saving emergency admissions at the intensive care unit and preventing breakdown in the home situation will help to save money. And we believe that this is a very, very typical case. We have several such cases, how crisis could be prevented. So what is the concept of crisis? And in the preparation of this meeting, we asked parent advocates and one of our team members, Kelsey, if you would come please, who is a medical anthropologist with her undergraduate degree So again, now that we are practicing multidisciplinary research, interviewed parent advocates.
Hello, everybody. I have 2 minutes, so I'm just going to jump right in. A crisis is an imbalance between the severity of a situation and the resources that you feel you have available to you. This imbalance is incredibly personal, so to find out more, we conducted some interviews. The first series were done with representatives from a series of organizations: Down Syndrome Research Foundation, Autism Community Training, the Children's Sleep Network Parent Advocacy Group, IDIC 15, and the UBC School of Nursing. All these representatives had very diverse priorities, but across the board, everyone felt that raising awareness amongst healthcare professionals, the general community, and impacted parents and families was incredibly important, and also reducing the impact on families dealing with sleep problems. From here, we conducted interviews with 10 parents and families contacted through these organizations. These parents felt that they were not listened to, and that their expert knowledge as parents was not acknowledged. Because they weren't listened to, the complex consequences of neglected sleep problems were missed by physicians and sometimes by parents themselves. Sleep in children with complex and chronic care was often missed and was rarely a priority. And after the fact, many parents looked back and realized that sleep problems were impacting the severity or frequency of seizures, migraines, or disruptive daytime behaviors. Parents weren't asked, what do you need and what are your goals? And because of this, the impact of sleep problems on the entire family wasn't appreciated. This meant that support services were not tailored to the family, and they were therefore ineffective or inefficient. The word empathy came up a lot. Physicians and healthcare professionals weren't trying to see the situation from the family's perspective, so they were missing out on actively listening and engaging with the situation. This lack of empathetic listening meant that treatment and options were not family-centered, so parents uncomfortable with medicating their children or who are unhappy with the adverse drug reactions felt neglected and helpless. So for these 10 families, crises wasn't necessarily acute, it was long and grinding, it was their day-to-day, it was their normal. And then after the fact, looking back, they were able to see how bad it was and that they were just coping, sleep deprived, and very desperate.
Once more the same graph. Here it is about what we treated was discomfort of the patient. We didn't give her downers or uppers in the morning and downers in the evening. We treated her discomfort. And the concept of capturing that is based on the qualitative research we are doing. And I'm not going in details. Dr. Cary Brown is a professor at the University of Alberta. She's an occupational therapist and deals with sleep, discomfort, and pain. And she's a core member of our research group because we believe that we have to treat as a key symptom discomfort and pain of kids. And with that we would achieve higher results. The question is how we capture information, and we are going to speak about it tomorrow.
Good afternoon. My name is Cary Brown. I'm a faculty member in rehabilitation medicine at the University of Alberta, and I wanted to thank the organizers for inviting me to talk to you briefly today. My research areas are in sleep deficiency and also in pain, and so these two come very much together when we're talking about children with sensory processing problems. I'm going to give you just a very short nutshell of some important facts, and then there'll be a link to the resources and the different URLs that I'm briefly going to mention here. The organizers are going to put that on a website for you, so you can go back and take more time to review a lot of this information. So the first fact is that children with neurodevelopmental disorders and sensory processing problems often have sleep and pain problems. Right? That's very common, and you shouldn't think that that's anything unusual. You know, we want to learn the tools so that we can recognize what those things are, but it's not an unusual event. The problem emerges, though, because when children have sensory processing problems and some neurodevelopmental conditions, it's much more difficult for them to communicate. And so instead of being able to talk to us about their pain and say, you know, Mommy, that really hurts when I do something, instead they communicate their pain through certain behaviors, perhaps rocking or facial grimaces or calling out repetitively. But they might not say, I hurt, I hurt, I hurt. They might, you know, use different words we don't know. So it makes it very complicated to understand what's going on. So because it's not easy to assess pain, oftentimes the behaviors that children are using to express their pain get misinterpreted. And the interpretation is that, oh, this is a behavior that's a consequence of their health condition. And people don't realize that it could actually be a consequence of a painful experience that they're having at the time. If you don't recognize the pain, then of course it doesn't get diagnosed, and if it doesn't get diagnosed, it doesn't get treated. And this is a big problem. Healthcare providers across Canada, surveys have shown us that their level of awareness of how to assess pain in children with communication problems is not as advanced as they would like it to be. I mean, healthcare providers recognize that this is a key need, and they're very, very eager to acquire the resources that they require, but that's still working its way through the system, right? A lot of this is new information that's being developed. Encouragingly, though, there are some assessments now that we can use with children who have problems with communication, and I've listed those at the end of the slide here. There are also some resources that can give us some more background, and we developed some here at the university. The OT Health Literacy website that's listed on the slide has all kinds of information that's for healthcare providers, for parents, and for children as well. So it's broken down into different downloadable brochures that you can access depending on what your need is. Pain and Child Health is a website that was developed by the Dalhousie University people, and it's an excellent, excellent resource. There's all kinds of background information as well as what to do, how to determine whether you think your child might have pain, and then what can you do about it, and what kinds of information is best to take to your healthcare provider. There's another tool that you can download that's called the Non-Communicating Child's Pain Checklist, and this is just a list of behaviors you go through and tick off, and then you can take that information again to your healthcare provider, and it gives you something to talk to them about to help illustrate why you're concerned about you're starting to suspect that your child is having some kind of pain, and this gives you a tool to discuss that with your healthcare provider. And then the last thing is the FRCPC, which is another assessment tool, but it's specifically targeted at children post-operatively. So a child comes in for a tonsillectomy, or they have some kind of a broken bone or something that's happened. They have to have an operation. And it's important that we have these tools as well, because children with sensory processing problems and neurodevelopmental delays also have to have surgeries. So that's very much it in a nutshell. The resources are going to be posted by the organizers at a separate site, so you can take a look at your leisure, because there's a lot of information here to digest. And I just wanted to thank you very much for your time and attention, and I hope you enjoy the rest of the day.
That I'm just showing one slide, and it will show you that these are kids with autism spectrum disorder from my clinic 28, and you see the age groups. You see that they get some over-the-counter or not over-the-counter prescription medications, and that second-generation antipsychotics and stimulants are used in a quite excessive way, even in kids below the age of 6, and we have strong hesitations about this situation. And I'm not going to show you further data.
Hello again. Okay, so the two phases of interviews that I spoke about a few seconds ago were analyzed and boiled down into their most fundamental parts. There's 3 of them. The first one is family impact. Parents need the impact that the children's sleep problems have not only on the child, but the wider family appreciated. Something as simple as asking a parent how they're doing in a clinical setting was seen as incredibly meaningful and really helped parents in coping with the overall sleep deprivation and anxiety and stress that they were dealing with. Parents themselves wished that they'd understand the impact that poor sleep had on their children and themselves. Families need more resources and support services, and these need to be easily accessible because these parents are sleep deprived and don't have time to spend hours online searching through resources. The second one is unified communication and goal setting. Communication between family and all healthcare professionals needs to be open and empathetic. Parents' expert knowledge needs to be respected, and professionals need to communicate across different healthcare sectors, particularly when dealing with complex and chronic cases. Goals set by one professional need to work with, not against, goals set by another specialist, and all goals and communications need to be centered around the family. Third is professional awareness. Healthcare professionals need to prioritize sleep. All professionals have a basic understanding of what is healthy and what is not, and professionals need to have resources available to them so they know where to get answers or to refer families who need help. They also need to gain insight across sectors by communicating between themselves, gaining insight into complex cases that aren't necessarily best dealt with by staying in your discipline. So I've interviewed 15 participants so far, all with a very diverse set of backgrounds. The parents I talked to have children with very, very unique and diverse social, personal, and medical histories. And when I was synthesizing this down, it was a bit stressful at first to see it this simplified, and I had a bit of a freak out, but later realized that this is actually incredibly powerful and wonderful that these diverse group of people, when it's all boiled down, have the same 3 goals, 3 needs, and 3 suggestions. I'd also like to take this opportunity to thank all of the people that allowed me to interview them. Your feedback and perspectives have been invaluable. Thank you.
Thank you. I think this really nicely puts it together. The round table will be about sleep disorders, the family impact, about developing unified communication and goal setting, also what Carleton mentioned, how to monitor, how to set goals and create evidence about that what we do, and of course professional awareness. The discussion will be, this is why we came up with this lovely logo, Sleepless in BC, Stop Shame, Stop Suffering, Share Your Story. We are interested in your stories, and the discussion will be moderated by Kelsey and Dr. Lori Plachungorod-Kani, who is an ethicist and the director of our clinical ethics service. We are trying to set a framework for a public discussion about 2 to 3 hot topics and how to prepare our